So this is a partnered talk coming together for the good of the histiocytosis and AVP-D or diabetes insipidus community. So my name is Deanna Fournier. I'm the Executive Director of the Histiocytosis Association, which is a global nonprofit organization dedicated to supporting the unique needs of patients, families, and providers around the world that are impacted by histiocytic disorders. I'd like to introduce you to one of your co-hosts for today, Fernando Goetz from the OR Association.
Thank you, Diane. Thank you very much. This is a huge
Todos.
honor.
Es para mí un enorme honor formar parte de
And it's feels so beautiful to really partnering with you and your organization. And this is the important message that I would like to deliver today, which is the important thing or the importance to be really connected and to work hand by hand. The histiocytosis organizations all around the world needs to work hand by hand to really deliver the message and to improve the life of all our patients and their families. So it's a privilege to have you all here. And I would like to say hello also to all the guys connected from Spain and from all the Latin American countries. So thank you very much.
Thank you. And I'd like to also introduce your third host for today, Pat Gilroy, manager and founder of the GOT AVP-D Facebook group.
Hi, good morning or afternoon, wherever you are. I'm in good morning. I'm really honored to be here and presenting with wonderful guests. And thank you, Deanna, for putting this together. Actually, I did not found GOT Diabetes Insipidus, and we have a very long name now. As a Facebook group, we have 6,900 members worldwide, and I've been the lead administrator for this group for about 8 years. And through that time, I came to recognize that many of our members first find out that they have arginine vasopressin deficiency, which was previously called central diabetes insipidus. And then I realized that many of them found out later that they had a histiocytosis condition. So I contacted Deanna at Histio Cytosis Association, and we began this mutual effort to educate members and other people about the relationship that can happen between these two. And I'm really happy to be here today to be able to assist others in finding our group and getting additional information. Thank you so much.
Thank you. And we're also honored to be able to partner together for you to bring you important topics and information such as this. And there's a lot of incredible work that's going on now related to arginine vasopressin deficiency or central diabetes insipidus and related conditions. And our groups are all really passionate about ensuring that we not only bring you the best information, but also provide you with the opportunities to engage in this research. And so we're really honored and thrilled today to be partnering with Dr. Chian Atila from the University of Basel in Switzerland. And he's put together a fantastic talk for you about what is diabetes insipidus and the relationship there to histiocytosis, management, how to manage it safely, and a variety of other really important topics. And Dr. Atila is a thought leader in the space and what he's doing, and has just been incredible in terms of supporting patients and families with research. So without further ado, I'd love to turn today's talk over to Dr. Atila. And again, thank you so much for your time and for offering this for our communities.
So first I will try to share my screen before starting. I think you need to enable me to share my screen. Is it? Oh, no.
Try
okay.
now, yes.
Perfect. So I hope you can see my screen now. Is it the presentation mode or the normal full screen?
It's presentation, it looks good.
That's okay?
Yes, full screen, sorry, yes, it looks
So
good.
I will just So first of all, thank you very much for inviting me. My name is, as already introduced, Chian Atila. I'm working as a physician here in Switzerland. at the Department of Internal Medicine and Endocrinology, and have a focus research in pituitary disorders with a particular interest in central diabetes insipidus and arginine vasopressin deficiency. And I know how hard it is for patients because it is a rare disease. And that's why I asked Pat and the Histio Association to put together a presentation where we can discuss how to manage vasopressin deficiency, and also talk about some future aspects, and also to have some inputs back from you patients. So I'm very glad to be here. So for the next 30 to 40 minutes, we will talk about the pituitary gland, just give you a basic idea of what the pituitary gland is, where it is located, and the endocrine manifestations of histiocytosis, in particular vasopressin deficiency, and then how to treat it, because this is not straightforward and this can be very challenging, and also about the complications. And if you have time, I will also talk by the end about some future developments which we are, what kind of research we are conducting here in Switzerland, to give you an idea about new research areas which will be maybe relevant for you in the future. So I will start with a clinical case. On the left-hand side, you can see a discharge letter of a patient here from the University Hospital of Basel. It is in German, but just to give you an idea, it was a 71-year-old patient admitted to the surgical department with nausea, vomiting, and headache. And if you look in his diagnosis, we can see he has an otitis, meaning that he has an infection of his ear. And then below you can see he has diabetes mellitus type 2, and then hypokalemia. We were asked from the surgeons, because the patient was admitted to the hospital with a very low sodium of 120. So the normal range is 135 to 145. So it was very low, and the surgeons were not sure why the patient had such a low plus blood sodium level. And if you look into his medications, we can see he is taking something for his high blood pressure, an antibiotic, and a nasal spray. After 1 day and 2 days, we figured out that the patient had no diagnosis of diabetes mellitus, but a diabetes insipidus, which was wrongly diagnosed or written as diabetes mellitus. And interestingly, his low sodium level was induced by desmopressin. And desmopressin, because this nasal spray which he is taking was a nasal spray which contains desmopressin. So why did I choose this case? By the end, this case was a Histio patient with a manifestation in his ear and with a manifestation of his pituitary gland, and he had a diabetes insipidus, and he was previously diagnosed with that, but wrongly in our discharge letter, in our diagnosis in the hospital, and he treated him too much with desmopressin. That's why he had a very low sodium level. So why did I start with this case? Well, the term diabetes insipidus is very confusing for the medical healthcare workers, because it is a rare disease. And we know diabetes mellitus very well. It is a very frequent disease. So what we did 2 years ago is, together with our patient representative, Pat Gilroy, to put together a study and ask over 1,000 patients with diabetes insipidus whether they had such experiences of confusion with diabetes mellitus, and whether they would support a possible renaming of the disease. And interestingly, in this survey study, we had a lot of comments about confusion with diabetes mellitus. Some of them were quite, I would say, funny, and that's okay maybe for the patients. But we also had some cases where patients got constantly tested for blood glucose levels, or that they received diet for type 2 diabetes. And in even some cases, they woke up, for example, from a surgery, and there was an insulin drip, which is supposed for patients with diabetes mellitus, or that they do not tend to tell their doctors that they have diabetes insipidus because they are afraid that can be confused. So we asked our patients, these 1,000 patients, whether they encountered a situation of confusion by healthcare professionals. And out of these 1,000 patients, 80% had such a situation, and 85% supported a renaming of the condition from central diabetes insipidus to arginine vasopressin or vasopressin deficiency. It was important for the patients to not use the term diabetes in the new name. So that's why we will introduce the new name in the next years in our publications, and it will enter clinical practice. In response to this study, a working group was set up to work on the new name for the next years, and it will enter the practice and also the research area, and we will change slightly from central diabetes insipidus to arginine vasopressin deficiency. That's why I will use both terms in this presentation. So back to the topic, histiocytosis. I will not talk about histiocytosis itself, but just to give you an idea what the disease is. Our bone marrow is responsible for producing our blood cells. We have different kind of blood cells, and if you have a dysregulation in particular subtypes of cells, you can get histiocytosis. And we know that there are different forms of histiocytosis, and each patient has a different manifestation. In some cases, it's only the bone. In other cases, it is the lungs. In other cases, you have only the pituitary gland, which is involved. So we have different forms of histiocytosis, and here are some common ones, and I assume that some of you have these subtypes of histiocytosis, for example, the Langerhans cell histiocytosis or the Erdheim-Chester disease. We know that in histiocytosis in general, there is a large population of patients which have an additional endocrine manifestation. It is around 40 to 70% of patients, so very large proportion of patients can develop or developed endocrine manifestations. Only some subtypes usually do not manifest with pituitary gland involvement. Back to the pituitary gland. Well, what is the pituitary gland? The pituitary gland is also called the master gland because it is responsible for controlling and coordinating all important glands, hormone-producing glands in our body. So it can control by other hormones, for example, our thyroid hormone, it can control our adrenal glands, it can control our kidneys. So it's a very important gland in our body, which is located just in the center of our brain. And just to give you an idea about the different hormone which is produced by the pituitary gland, I put them together on this slide. We have a front lobe of the pituitary gland, which produces 6 hormones, and we have a back lobe, which is also called the posterior lobe of the pituitary gland, which produces 2 hormones.
Posterior, con 2 hormonas, la vasopresina y la oxitocina. Es muy importante mencionarlo, y lo es porque en la histiocytosis la mayoría de los pacientes desarrollan esta deficiencia, esta carencia de vasopresina. Un efecto posterior, la parte de atrás, de abajo de atrás de la glándula pituitaria, en un 20 o 30% de los pacientes, por ejemplo, con histiocytosis de células de Langerhans, y el 25 al 50% de los pacientes con enfermedad de Erdheim-Chester. En algunos casos, tenemos también deficiencias de...
For example, growth hormone is reduced, or your sex hormones can be reduced. Also your stress hormone, which is cortisol, and your thyroid hormone. But the most common hormone which is affected is vasopressin. So today we will talk about vasopressin, and why it is important to manage vasopressin deficiency well, and what complication can result from that. So I will just give you one basic concept of how our water balance is regulated. Imagine this is your blood system, and we have usually a normal range of sodium in our blood, which is around 135 and 145, which is the normal range. If you have too much water in your body, this sodium will dissolve in much water. So that's why your sodium level will decrease and you will have low sodium level, which is also called hyponatremia. So you would have too much water in your body. If you have too less or too little water in your body, the sodium which you have will only have a little bit water, which then causes to have very high blood sodium over 145, and this is also called hypernatremia. So it is important because what vasopressin is involved in this regulation. We have two features how to manage our blood sodium and our water balance. We have our kidneys and we can drink. And vasopressin is a very important hormone here because vasopressin can act in the kidneys and bring water back to your body. It's the same with drinking. You can drink water and this will fill up your fluid which you lose usually through your kidneys. If you have high blood sodium, that means you are dehydrated, your pituitary gland will release a lot of vasopressin because the normal idea is that you bring back water in your body and fill up the glass again, and you will also feel a strong thirst and you will start drinking. In response to that, your urine will be dark, yellow to brown. If you have too much water, your pituitary gland will stop releasing vasopressin, and this allows your kidneys to lose water. Your urine will turn pale, yellow, and you will stop drinking water. You are not thirsty at all. So that's how we usually manage our water balance in our body. What about vasopressin deficiency? So if you have histiocytosis with a manifestation in your pituitary glands, your pituitary gland will not be able to release vasopressin, for example, despite with being, for example, dehydrated and having a high blood sodium. That means you lose a lot of urine, which is also called polyuria, passing too much urine, and you cannot compensate by releasing more and more vasopressin. That's why you compensate this loss of urine by drinking. So that's the pathophysiology. So that's the problem in vasopressin deficiency. You are not able to release vasopressin, you lose water, and to compensate this loss of water by your urine, you drink. And too much drinking is also called in medical terms polydipsia. That's why we usually call vasopressin deficiency also as a condition which belongs to polyuria and polydipsia. And if you are histio patients and you think, okay, maybe you have this condition, you should first document your daily urine output and how much you're drinking. We define polyuria and polydipsia by drinking more than 3 liters a day and passing more than 3 liters of urine per day. So that's the first step. If you assume you might have diabetes insipidus, you should first assess your urine volume and how much you drink. So vasopressin deficiency can result from a lot of different conditions. And for histiocytosis, we know that's a rare cause of vasopressin deficiency. So on this graph, you can see the more common causes, for example, a pituitary cyst, or you have a for example, in a surgery in your pituitary gland. But for histiocytosis, this is this one, belongs to the infiltrative diseases. We see that is for vasopressin, it's a rare condition. So that's why we usually in endocrinology only have few patients with histiocytosis which develop vasopressin deficiency, and see also just a few patients. For years, if we suspected vasopressin deficiency or central diabetes insipidus, we performed the water deprivation test. And the idea is that we stop fluid intake in these patients for 17 hours. And if you are able to concentrate your urine, we know, okay, that there is vasopressin. We would exclude the condition. But if you are not able, after 17 hours of fluid restriction, to concentrate your urine, that's very likely that you have diabetes insipidus or vasopressin deficiency. However, this test was developed in the 70s in a very small patient group, and that's why it only has a diagnostic accuracy of 76%. That means that 1 in 3 patients will be wrongly diagnosed. And what we are doing here in Switzerland is to develop new diagnostic tests. And we develop different ones, which we call hormone stimulation testings. The idea is that we apply a stimulus. We have different ones, which I will explain in a minute. And we measure vasopressin after the stimulus. And we cannot measure vasopressin, but we can measure copeptin. That's a part of vasopressin. If vasopressin, or in this case copeptin,
Y si esta copeptina aumenta, sabemos que el paciente puede generar la hormona, se descarta por tanto la deficiencia, pero si no se puede liberar la copeptina, entonces ahí tenemos un diagnóstico.
we have different tests available, and I will not explain these tests, but just to know if you are if you have the ability to have an endocrine expert who can perform these new tests, and there is a suspected case of vasopressin deficiency, you should prefer these cases because, for example, for the hypotonic saline stimulation test, the diagnostic accuracy is 97%. So with this test, we can almost clearly diagnose 100%, almost 100% of the patients. Once you have the diagnosis of vasopressin deficiency or central diabetes insipidus, we can replace the hormone with desmopressin. Why can't we use just vasopressin? Well, we could use vasopressin, but the problem is vasopressin is only lasting a few minutes. So you would need every few minutes a hormone replacement. And that's why we developed over the years different formulations of desmopressin, which last longer, 6 to 8 hours. And it has the same function as vasopressin. It brings water back from the kidneys in your body. However, the main complication of desmopressin treatment is hyponatremia, meaning low blood sodium, so too much water in your body. There are different desmopressin formulations and types available. And today we know that most of the patients prefer or take the oral tablets, but we also have nasal sprays, sublingual tablets. Some of the patients even prefer not to take medications. Some of patients take combinations of these different forms. And we asked our patients, these 1,000 patients, whether they changed from one type to other type. And interestingly, most patients changed over the years from the nasal formulation to the oral tablets. Most commonly because it was not available, nasal sprays, or because of the personal preference. Why should we care about low blood sodium? Why is it important that we educate our patients about hyponatremia? Well, mild forms of hyponatremia can cause, for example, fatigue, headache, and reduced appetite. Moderate, so more severe forms of hyponatremia, however, can cause muscle cramps, confusion, nausea, And very severe forms of hyponatremia can even cause vomiting and seizures. So it is very important for the patients to know what are the side effects or the symptoms of hyponatremia, because depending on these side effects, you should go to a hospital or not. And if you have a seizure or nausea with vomiting, that's a very important signal for you or your parents or your partner that the emergency room should be contacted. So it is important for the patients to understand that desmopressin works different than other medications. It is not like a drug which we, for example, take for high blood pressure at the same time every morning, because desmopressin works different depending on the context. We know that a lot of factors are there which can influence how long desmopressin lasts in the body. For example, stress, sports, what you are eating, the temperature, psychological stress also can influence how long desmopressin will work in your body. And I will try to explain it with one figure. We know that, for example, if you do not prefer to eat salty, if it's cold outside, and if you are, for example, relaxed, desmopressin will maybe work longer. That means that this is, for example, a representation of desmopressin dose in your body, which lasts in this case longer, because if you take desmopressin, you stop losing urine and you stop drinking water because you're not thirsty. If desmopressin dose is somehow immediate in your body, you will start losing a little bit of urine and you will start maybe feeling thirsty. But if desmopressin is not working in or is completely out of your body, then you start again with the polyuria, meaning that you pass urine, which is yellow to pale, and you feel the thirst again. In the next day, maybe you eat a pizza or more salty, it is maybe warm outside. And in these cases, we know that desmopressin will be influenced. And it could be that in one day you have a desmopressin effect of almost 2 days. The next day you will only have an effect of 2 hours. So it is very important to know that desmopressin can be influenced by many, many factors. And that's why we must educate our patients how to use desmopressin. Because imagine you are taking desmopressin every day at the same time. So every day in the morning. We know that in some cases, desmopressin works longer, in some days it's not so long. So let's imagine desmopressin usually works longer, but your doctor told you you should take it every day in the morning. So you will start taking desmopressin. It will work. Usually you would start with your symptoms after, let's say, 1.5 days, and you will start losing water in the next day, but let's say evening. But your doctor told you you should take it every day in the morning. So you would take it in the morning again and again and again. And you can see that by time you increase your desmopressin dose in your body. And with that, you hold water back in your body. And that's why you develop hyponatremia over time. So how should we perform, or how should we use desmopressin? Well, ideally, you should take desmopressin as needed. What does it mean? You should take desmopressin and wait or delay the next intake until you have so-called breakthrough symptoms. What are breakthrough symptoms? Breakthrough symptoms are the symptoms that your body recognizes it has no desmopressin anymore. So it will start losing urine again, which is yellow, not brown. You will have a full bladder, and you will also feel the strong thirst again. So basically what you do is you take, for example, a desmopressin dose, then you wait until you have breakthrough symptoms, and then you take the next dose. And then you wait again, and then let's say the next day it lasts longer, and then you start again with your symptoms. So strong first, full bladder, pale urine, and then you take the next dose. So that's the ideal management method, how I usually treat my adult patients who are conscious about the disease and know how to manage it. But as you can see, this can be somehow difficult for some patients. So sometimes I recommend another concept, for example, taking it more or less at the same time, but once a week or twice a week, you delay desmopressin dose and you reset your intake time. So you can see, for example, this patient took his desmopressin at 8 a.m. and 8 p.m., but then he had once a week a delay. He performed the desmopressin escape method, so waiting until he experienced breakthrough symptoms, and then he takes his desmopressin again on a scheduled base. So sometimes this can be also helpful, especially in the context of your profession. It might be challenging to delay it at each dose. And then I also have some patients who prefer to skip a dose once a week or twice a week. That's also an option to get rid of the water, extra water, at a particular time. And usually I perform or recommend this method, for example, for elderly patients at the weekends, to skip one dose, let's say on a Sunday or on a Saturday. So there are different methods available how you can use this so-called desmopressin escape method, but it is important to know that to allow your body to get rid of this extra fluid, which is definitely helping. So why is it helping? In this larger study which we performed, we could demonstrate that first, hyponatremia is very common. In the outpatient, meaning in the normal population of patients, it is 22%, so quite high. In 26%, even leading to hospitalization. So 1 in 4 patients, it can be severe, and in this case, you should go to a hospital. But if you perform the desmopressin escape method, you will have the lowest risk in comparison to patients who are not aware of the desmopressin escape method, which have a higher percentage of hyponatremia, as demonstrated here. So we can see that patients who are aware how to use the desmopressin escape and to take it as needed have a lower risk of hyponatremia. So what we did is, together with Pat, we designed a small information sheet for patients, which we usually hand out. You have a few information about the desmopressin escape method here with the important symptoms. You have the different options, which I explained. And on the right-hand side, you can see the symptoms of low blood sodium, so hyponatremia, mild symptoms, moderate symptoms, and severe symptoms, what you should do and what you can do if it's, for example, mild. So that was about hyponatremia, having too much desmopressin and water in the body. But what about if you have no desmopressin available and you cannot drink water? That's also a very important complication, and you should, and especially your family and also your partners, your environment should know what to do. So imagine you have no vasopressin. You are vasopressin deficient. So you will lose water through your urine, and you are not able to take desmopressin. Let's say you are in a surgery. Well, in a surgery, you are also not able to drink water. And in this case, you will lose water, but you cannot compensate the loss of water by drinking. And in this case, your blood sodium will increase, meaning you are dehydrated, you have too little water in your body, and which will cause hypernatremia. This is important because usually hypernatremia develops during hospitalizations. In our study, we asked patients about fasting states during hospitalization, which is usually performed, for example, for surgeries. You are not allowed to drink water, you are not allowed to eat before a surgery. But usually you should receive, if doctors know about your disease, intravenous fluids, so through your veins fluids to replace the loss of fluids. That's completely fine. If you receive fluids, that's okay. In some cases, however, you do not receive fluids, but usually the doctors should give you your desmopressin that you can hold back your water in your body.
Pero puede que algunos no la
You can either use your desmopressin or you receive fluids to manage your body water. But in our study, about 12% received no desmopressin, and they received also no fluids through their veins. So in these cases, they are at risk of losing too much water and getting dehydrated. And these symptoms and these patients classically told or well, they had classic signs of dehydration, and that's completely well. If you are aware of these symptoms, that's fine. You can ask for water, or you can also talk to your doctors. But in some cases, you are unconscious and you cannot explain or talk to doctors about the disease. That's why your family and also your environment should know what to do if you're unconscious, if you're not able to take desmopressin or take fluids. So that's why it is important to have informations available in your, for example, in your pockets with a small card. And I will explain where to find such small cards where you have a small information for the doctor that you have the condition, or at least your family and your partners should know what to do. So that's why we also developed a leaflet for healthcare providers, for physicians, for surgeons, how to manage desmopressin during the hospitalizations, especially in a surgery situation. So if you have the preparation for a surgery, for a surgery, we have some information here for the doctors during the surgery, what to do, and after the surgery. And it is important to provide your doctors with these informations, because we know that this is a rare disease, and usually especially in smaller hospitals, they are not experienced with how to manage patients with vasopressin deficiency. Where can we find all this information? And I want to definitely recommend a very important homepage from the Pituitary Foundation. You can find access just by scanning with your phone this QR code. And you have all this important information. For example, the awareness card, which you can take with you, the surgery flow chart, which I demonstrated, but also the card which demonstrated the desmopressin escape method and how to perform the desmopressin escape method. So in conclusion, if you have the suspicion that you might have vasopressin deficiency, you should ask for so-called copeptin-based simulation tests. Which is currently the gold standard in the diagnostic evaluation. You should know about hyponatremia, meaning too much water in the body, and also hypernatremia, meaning too little water in the body, so being dehydrated, as a frequent complication in this disease. And you should also tell your doctors not to use the term diabetes, instead vasopressin deficiency or arginine vasopressin deficiency. And then for the renal forms, this is another subgroup, vasopressin resistance. In addition, I want to check my time. Well, I have some few slides also for oxytocin deficiency, but if you are happy to make a break here, we can also make a break, discuss first the topic of vasopressin deficiency, or skip completely the oxytocin deficiency part. It is up to the patients here, because I think we talked about 40 minutes now, and it will maybe take additional 10 minutes. How should we proceed?
Dr. Atila, there are quite a few questions that have come in. So if you want to field a couple of them and then if you want to save some time for the oxytocin slides, that would be great as well. But there are a few questions if you'd like to field. If you pull up the Q&A box, we can either field them for you or you can select them if you'd like. But I do see some comments that they would love to hear about oxytocin as well.
Okay, perfect. So we can start. You can just read them and I will try to answer and we can discuss about the questions. That's completely fine. Should we just, I don't know, I have a lot of questions in Spanish.
I cannot see the questions in Spanish, so I'm not sure where you can see them.
Okay, I will. Fernando will.
But related to the question, maybe we can read some of those questions that we already had.
Leerlas, algunas de las que ya te...
If you want.
That's
So,
perfect.
yeah, okay. So one of the questions was, I think that for some you already touched many of the questions and they were already answered, but let's see. So Jacob was saying if having this as a result of the LCH indicative, or is it an indicative for future neurological problems? Is thickness stocked indicative for active LCH? I don't know if you prefer to answer to these questions now or if you want to wait for the end.
That's fine. So we can talk. Well, that's a very important question because if you have histiocytosis in general, we know that the endocrine manifestations are quite common. And if you have an endocrine manifestation, it is likely that in 20 to 30% that other hormones are also involved, not the brain itself, but other hormones. So as I demonstrated, we have different hormones which are produced in the pituitary gland, and the most affected hormone is vasopressin. But if you have histiocytosis with vasopressin deficiency, then it is likely that you might have in 20 to 30% of the cases an additional hormone deficiency. That can be, for example, cortisol, so stress hormone deficiency, that can be a thyroid hormone deficiency, that can be a sex hormone deficiency. But usually, if you have a diagnosed vasopressin deficiency, you should have been diagnosed or tested at least for these other hormones as well. So what an endocrine expert is doing is assessing all these hormones in the evaluation of patients with histiocytosis. So we do not only look for a vasopressin deficiency, we usually in our consultations look also for the other hormones. And it is important for our patients to know that you should go to your endocrine expert every year to check for these hormones, because sometimes it is only partially involved, sometimes it can change a little bit. And if you also have the feeling that there is something different, you can definitely go to your endocrine expert and get tested for these hormones. So I see my patients once a year and I usually test all these hormones.
Thank you, Chian. One question from Danielle, and I think it's very related to Daisy as well. You already touched a little bit the point of why does the stress causes a difference or a differentiation between the absorption, let's say, to absorb the or not, and if it does dysregulate everything, that if it's that a reason for dysregulating the absorption of the vasopressin.
Yeah, so that's a very important point. So I demonstrated you that there are different formulations of desmopressin. We have tablets, we have nasal spray, we have sublingual tablets. So we have different melting tablets, we have different forms, and each of these forms has its disadvantages and advantages. And we know that there are important points that we must educate our patients. For example, if you take the oral tablets, you should not take it together with a meal. Because if you take it together with the meal, the absorption in your gut will decrease and the effect will only last a few hours. It is, for example, with the nasal spray, it is very, very challenging for some patients because even the application, how you apply the nasal spray, can change the absorption of desmopressin in your nose from day to day. So it is important to know that, but in my opinion, it is more important to know the symptoms when to start taking the next dose again. Because we can educate our patient and say, okay, we should not take it together with a meal, definitely not. We should maybe take it, for example, prefer it the oral route, which I prefer because the nasal spray has slightly higher risks of hyponatremia. But the most important message is, to my opinion, to educate our patients that they should take it as needed. And if you have only a few hours and it starts again with polyuria, meaning that your bladder is full, you run to the toilet again, it doesn't matter if it's nasal or oral, you should take the next dose then.
And can you, adding into that or continuing into that, and it's a perfect explanation what you have said, is there a way or is it feasible to combine? Because you mentioned the thing that if you don't have vasopressin or maybe the nasal, you have the nasal thing, but you also have the pills. Can you combine between those if you know, of course, the doses, your
Yes.
dose and what is good for you in case you don't have something? Just use vasopressin in another way.
That's that's also a very important question. So what I usually do is, for example, I have a patient who is treated with oral dose, so oral tablets. I usually prescribe him additional sublingual tablets because, or nasal spray, whatever, because we know that the effect will be different than if you take a tablet and then you have to wait and it starts 30 minutes later and so on. But for nasal spray, usually it starts, the effect starts quite fast. So you can have a rescue medication with you. Let's say, for example, you are in a train, you are, I don't know, in a meeting, and you feel it starts again, that you have a rescue medication with you. And usually the sublingual tablets or the melting tablets are working quite well. And also the nasal spray is a stronger one, which is quite fast in the effect. So what I usually do is I prescribe also a additional rescue tablets formulation, sorry.
Excellent. There are lots of questions I see here. I am trying to somewhat read, also hear your answer, read also between them. Maybe you want Diane to
Sure.
already. Yeah.
I can take another one while you look, Fernando. There
Yeah.
are several questions about how to sort of manage the desmopressin depending on whether you're sick, if you're an athlete, kind of, and then age for 3-year-olds. How to kind of manage that escape depending on the age that you're at, how active you are, and then whether or not you're sick. Any tips on how to monitor and manage desmopressin depending on different circumstances?
Yeah. Well, I have to say, first of all, I don't treat children and kids, but the general concept for all patients is to have a good feeling of your symptoms. So it doesn't matter if you do sports or if you're an athlete or otherwise, if you are working in a very stressful environment and have once in a while it's very stressful periods and then other ones very relaxed periods. You should know what the symptoms, classic symptoms are if your body has not enough desmopressin. And depending on the symptoms, it can change from day 1 to the next day, to day 2, that your dose will double from one day to the other day. If you, for example, an athlete and you need water and you are sweating and you perform you do your sports, then it's most likely that you will lose a lot of water and you will maybe take your second dose. But the second dose should be then taken if you start again with the symptoms. So for those who are conscious about their symptoms and who know what's the classic signs that desmopressin is not in your body enough and is gradually decreasing, that's perfectly just to know it is with strong classic first, full bladder, pale urine. That's the sign which you should know. And depending on this signs, you can then take the next doses. And I mean, I'm not a patient, but I think we can also hand over the question back to Pat, for example. I mean, she's very well experienced how to manage the desmopressin. And Pat, what do you do, or how do you manage your own desmopressin? I mean, we talked about athletes and small children, but in general, what information would you give back as a patient? So how do you monitor?
We generally recommend, well, for me, I prefer to have breakthrough every day. I can tell immediately the next day if I don't have breakthrough and I feel a little heavier. We suggest to patients that they weigh themselves every day, and if they have an increase of 3 pounds or 1.4 kilograms, that it might be time to have a little longer breakthrough, because it's really likely that that's extra fluid. With children, a lot of our parents like to have breakthrough prior to most doses, especially little tiny babes. And then they don't wait for a long breakthrough, but they wait till they have a couple of heavy diapers. and then they
Sino cuando ven, por ejemplo, que hay 2 pañales muy llenos, ahí dicen, ven que es el momento, porque tiene que estar regulado con la cantidad de fluidos. Los atletas, o, por ejemplo, yo si tengo
traveling or something, I will not have breakthrough that day. I'll take extra desmopressin and make sure that I have a longer breakthrough on the next day. To our members, we do a lot of coaching on this in gut diabetes insipidus, and we recommend that the safest is to have breakthrough every day. But if it's more convenient for them to do it several times a week, then that's fine. I'm much more cautious about saying once a week, because it's too easy to put that off and say, oh, well, I'll just do it next weekend. And then you end up with the problem of really getting excess fluids. So I hope that met the criteria for what we do with different situations.
Also,
That's
Pat,
very
thank you.
important.
Thank you very much. And I think that, of course, what we are saying here depends from case to case and from person to person. With the most important thing would be that in case of doubts, of course, go into your endocrine and ask if you can change and those. One of the questions that I have here, that it's also one of my favorite questions, because of course here I'm talking also as a dad of a patient that is already managing the DI for many years. If the DI is something reversible for LCH patients in some cases, because we know that it may change from patients, and there are, as you said, times that the desmopressin works better or not, but there are many times that it disappears for some reason.
Yeah, so that's very important, and also which also an important message to our patients, because desmopressin dose requirement will change. So it can be that by the beginning of your diagnosis, you have 2 tablets. After years, you only have 1, or other way around, you will have maybe four tablets. So it can completely change. It depends on your age, on other hormones, a lot of different factors. So that's completely fine, and we do not care about fluctuations at all. But there are some cases where you don't need any desmopressin at all, and that means that you recovered somehow from vasopressin deficiency. And there are only few cases. Usually these cases have pituitary surgeries. They have for a few months, maybe in some cases for a few years, vasopressin deficiency, low levels of vasopressin in the body, but your neurons then after years recover, and you can somehow produce again vasopressin. For infiltrative diseases as histiocytosis, I have to say, unfortunately, it usually lasts. So you do not often recover fully from vasopressin deficiency if you have histiocytosis, because histiocytosis in the pituitary gland, if it is a pituitary manifestation, it usually is quite destroying the cells too much that you cannot recover very well as someone who has this damage because of a surgery, because during a surgery, you usually do not, you only cut the lower parts of the neurons, and that's a chance for the patients to recover because you still have the neurons which are located a little bit higher than the pituitary gland. For histiocytosis, is usually the pituitary, upper part of the pituitary, the stalk, which is involved. And in these cases, we usually do not often see recover. But I have to say, I mean, I have histiocytosis patients, and for them, I know it is an annoying disease and it is not easily to manage, but still, it is, I think, if you only have vasopressin deficiency, you can manage it well. But for recovery, I know that it's a little bit different than other cases. So unfortunately, usually it lasts long.
Okay, for the sake of time, okay, we are already like 1 hour presenting or 1 hour of webinar. I don't know how much time do you want to go on, Chian, or if you can stay. So because of the oxytocin, because I know that it also did has a lot of interest. So if you want to continue with that, do you have like 10 or 15 minutes more to continue?
Yes, that's fine. I will only
Yeah.
show some slides about oxytocin deficiency, just to
Okay.
give an idea about the next years, because it will be relevant for the patients, and that you hear about oxytocin deficiency for also maybe research purposes, because we are currently developing new medications for that. So I will try to share my screen again. Okay, so, well, in the study which I explained in the beginning, so 1,000 patients which we conducted together with PET, we also asked about psychological problems in patients. And interestingly, about 25 to 30% of the patients reported that they recognized some kind of changes subjectively related to the onset of their disease. So importantly, most patients reported about slightly higher anxiety, meaning that they had, for example, problems with social environment, a social anxiety, that they had slightly lower mood, so a little bit depressed, and also were impaired in some social domains, and overall reduced quality of life. And this is very important because usually we know these symptoms for other hormone deficiencies, but for vasopressin deficiency, we would treat the problem with desmopressin, and that's it. But despite treatment with desmopressin, I see a lot of patients with vasopressin deficiency. All these patients always commented on some kind of changes. And if you go back to our pituitary glands, we know that for all these hormones, if you have a deficiency, you can treat it with hormone replacement therapy. So we have different hormone replacement therapies. For vasopressin, we have nasal sprays, tablets, melting tablets, and then so on. But the only hormone which is not treated currently is oxytocin. That's because we currently do not have a disease which is called oxytocin deficiency. Oxytocin is also called the love hormone, the bonding hormone, the trust hormone, because it has very positive effects in the body. We know it buffers stress, has anxiolytic effects, is involved in emotion recognition. And one could assume that if you have a problem in your back part of the pituitary gland, which causes vasopressin deficiency, you might also have additional oxytocin deficiency. And this might maybe explain these symptoms which usually patients have, for example, as again, anxiety, a little bit reduced quality of life, lower empathy. But I want to stress out, these symptoms are usually not as severe, usually a little bit of those. And that's why a normal endocrine expert will not do anything with these little bit symptoms, let's say. And what we did is we looked into these problems in more detail, and we could see that patients with vasopressin deficiency had higher levels in the inability of identifying and describing emotions, higher levels of anxiety, and also a little bit higher levels of depression. So there was a clear difference between healthy controls and patients with vasopressin deficiency. And what we then did is we looked for a possible oxytocin deficiency. However, oxytocin deficiency, again, was not described as a condition. So what we did is we used a new stimulation test with MDMA. We know that MDMA is a drug which can increase your oxytocin in your body. This is very well described for 20 years. So what we did is we treated, or we performed a study and gave MDMA in this study situation to healthy controls. We could see the expected increase in oxytocin. It's an 8-fold increase in oxytocin. This is expected in the healthy controls. But for patients, we only saw a slight increase, and the difference was 82%. And this was the first study demonstrating that patients with vasopressin deficiency are likely to have also oxytocin deficiency. Interestingly, in this study, we also looked for effects of oxytocin, for example, liking the effect, feeling high, happiness, openness, and also fear reduction. In blue, you can see the effects in the controls, in the healthy controls. In red, you can see in patients. And as demonstrated, the effects were higher in the controls than in patients. So we can say that there is, or it is likely that someone also has an additional oxytocin deficiency, but we do not know currently the relevance of oxytocin deficiency. Is it only a little bit and it doesn't bother, or should we maybe treat it? So that's why this was described as a new human disorder, and we are currently investigating in a study whether oxytocin treatment, so replacement therapy, would help also patients with these symptoms, so reduce quality of life, depression symptoms, and also anxiety. In Switzerland here, we are conducting a study, and it will be conducted in Germany and most probably in other, also I think in Brazil, most probably. So we will try to open new centers and treat our patients for a month and look for the effects of oxytocin. And maybe in the future, this will be also an additional option of treatment for our patients with vasopressin deficiency to have additional oxytocin replacement therapy. So if this final slide, I now want to conclude my talk, and we can talk again the vasopressin deficiency for the next few minutes, and also oxytocin deficiency if you also have some personal experience with your changes. Okay.
Excellent, Chian. Now I am also trying to read again. There are, of course, a couple of personal cases, which I'm not sure if we can go through them because they are super personal. What we can try to do is, of course, gather those questions and try to do a follow-up with the patients that are asking, because we won't be able to answer. There are many, and they are very interpretative for each one of the cases. So I don't know if exactly, well, one of the questions here from Evangeline, I misread her name, is how is oxytocin deficiency diagnosed?
Well, yeah, that's a very important point, because we currently have no stimulation test. We need this stimulation test because you cannot measure oxytocin in your, let's say, urine or in your blood and say that you have a deficiency or not. You need a stimulation test, as we performed. But MDMA is not approved yet for such purposes. It will be improved in a few years for another condition. So physicians will be able to use this stimulation test in a very controlled setting. But currently, we do not have a stimulation test. So what we do is here in Switzerland, is that someone who presents with vasopressin deficiency, so central diabetes insipidus, and has symptoms which might relate to oxytocin deficiency are included to our study, and we treat them as they would have oxytocin deficiency. And what I'm currently also doing is I perform another study with a low dose of MDMA, which is not dangerous, just in preparation for the next years, because we know that MDMA will be approved in the next years. So we will be able to use it officially. You should not use it in privately. So that's very important. And so we will be able to use it in a controlled setting, and then we can formally also make the diagnosis. I'm very happy if you're interested in participating in a diagnostic study, because I will start one with a low dose of MDMA in summer. So if you're interested, if you want to get tested for it, you can fly to Switzerland. We will cover your accommodation and flight costs. That's no problem for us. And you can get tested here in Switzerland. That's fine for us. But currently it is not available commercially.
Oh, that's super interesting, that part, this last part. So of course we will be communicating all this also because we have everybody, all the registered people here. So we will continue giving information about your studies and the things that you can also share with your community. For the sake also of the translator, because it's already a lot of time that she is translating. So I was listening to the Spanish channel, of course. So Maya, thank you very much for your hard work. I will also send you, Chian, to so you can hear yourself in Spanish with her translation. It's very sympathetic, but it's really a tough task to do, to translate all this medical material. So thank you very much, Maya, for doing this work. So we are going to wrap up here, okay, to try to conclude the session. And yeah, telling everybody that there is a lot of material in the Histiocytosis Association website. There are a lot of resources. Again, what I said at the beginning, this is a global effort. Whenever you don't find information, please feel free to go here and see all the material that they have. They have material, of course, about the DI and the AVP-D. I will need to also get used to that term. Sorry, Chian, for that. But there is a physician directory for all the countries that there are in the world, physicians, centers of awareness kits, awareness tools, peer-to-peer connection. So there is a lot of things in the Histiocytosis Association website. And it also has a directory even of the associations abroad. So you can really get a lot of information from there. Diane, you are there. So if you want to comment something on that, if not, I will pass to Pat also to say a few words on her organization, if you want to, Pat.
Okay, thank you. I just wanted to let you know that diabetes insipidus is available to anybody who has joined Facebook. You do have to look it up by Got Diabetes Insipidus. We have a very long name now. It's also got arginine vasopressin deficiency. So go ahead and find us. You do have to answer the questions to join the group. It is a private group. And we have lots of resources. We have many of the resources that you have seen here. We will direct you to specific resources when you post questions. We also have guides. A particular one is if you think that you may have an issue with potential diabetes insipidus, what is a diagnostic process like? It gives you some steps to follow to be able to have doctors pay attention to you. We also have other resources, and I'm working with the Pituitary Foundation in England and in Ireland to update their materials as we're getting new information in. And it's been great working with this team in multiple ways. And so I appreciate that help. And I look forward to getting some new members with Got Diabetes Insipidus. Thank you so much.
And also, if you want to contact Pat, in case you don't find let's say the Facebook group, you can also contact the Histiocytosis Association, and they will also contact with Pat So there are many ways to contact in case you want to contact with that specific group as well.
Thank you.
So there is also a brief survey following this when we end the meeting, okay? One of the, I think that I skipped one of these, which was also, okay, something that I wanted to say, that a next, let's say, an upcoming event that we have also for patients, for histiocytosis patients, for adult patients, we are creating an international group with Spanish speakers, okay? So all the Spanish speakers in the world can join this effort, and it's a collaborative effort, again, between our association and the Histiocytosis Association in the US. So we will be sending also information and many in social media in order you to join. The next session, the session, the opening session will be the 16th of April, so in about 2 weeks. And also, in case you want to see more information in Spanish, you have it in our association here.
I forgot a really important thing.
Sure.
Can I interrupt? I've been
Sure,
working on a survey for 8 months. You would think I would remember this. We are about to release a worldwide survey for people with and caregivers for people with arginine vasopressin deficiency. We also have a section of that survey that specifically addresses women with this condition. And we've worked very closely with the histiocytosis community and have a whole section on histiocytosis. So we're really trying to look at this broadly. It should be coming out in the next couple of weeks. So we really hope to get as many people to take the survey as possible. We will have the addresses available in multiple forums, and hope we get some responses from you. Thank you so much.
Excellent. So here you have all our contacts, okay? In case you have, again, an extra question to Chian, you want to contact him by email. I believe, Chian, that maybe if it's even very, very complicated question, it's better that the doctor writes to you, the endocrinologist of the patient, in order to present the case in case really needed. And here are our contacts. And I don't know if Diane is already there. Diane, do you want to say goodbye? Are you there? Are you there? Yes, you are.
Thank you so much, everyone. Thank you so much, Dr. Atila. This was fantastic. I know there's a lot of great questions. So if you want to follow up with any of the contacts on the screen, you're welcome to. But thank you so much. And we look forward to continuing to share more information about this and future research opportunities.
And I'm also
Gracias.
very, very happy if you have any questions, and also if your endocrine physician has some kind of question. I'm very happy to answer these questions, because usually it is a rare disease, and also the experts have only few patients. So I'm very happy if they have some lab results or struggling with the diagnostics to look over the tests.
Thanks so much, Chian. Thank you very, very much. It was super helpful and super useful information. I am saying that as a user as well, means for someone with experience on this. And also I got feedback from doctors that are also participating from Latin American countries here, and also from Europe, that are saying that this is very useful information also to be shared with the medical community, and we will share it with the Histiocytosis Association and the Histiocyte Society in order to have this material available. So thank you very much.
Thank you.
Thank you. Thank you, everyone.
Bye.
Gracias, Mike. Thank you.